Hey, welcome back to our video series here on torn labrum. In our throwing athletes, some of the things that we do with the labrum are really more of a distraction-based or traction-based mobilization, or something where we're gliding the ball in the socket away from damaged tissue. Sometimes some of these mobilizations get demonized based on how they're applied or incorrectly applied. One of the things that we often hear discussed online as far as manual therapy for labral tears are the necessity of the posterior glide in our throwing athletes because they lack internal rotation. That's something we've covered in another video. I'm not going to waste our time on the assessment of that in this video. However, what I will say is the posterior capsule, or the capsule at the back of the shoulder, is not the most important thing when we're looking at the shoulder and internal rotation in our throwing athletes. What is maybe the inferior capsule or the posterior component of the inferior capsule. So we're going to work on that here with one of our favorite mobilizations for athletes, specifically for throwing athletes. What we're going to do is we can do this with traction, where I'm actually going to use my hand here on his humerus to pull, or a compression where I compress it into the socket depending on what I want to see. If we're working on internal rotation, I'll take him to the point of passive resistance-free motion where he starts to get a little bit of resistance in the tissue, internal rotation. I'm going to apply a little traction in Tony's case here. I'm going to take my cranial hand just off of the acromion, drop it just off the acromion onto the humeral head. I'm not going to lose any elevation here of this hand here on the humerus. That's going to stay up on my hip. I'm going to take him to the point where I start to feel that humeral head pop up into my hand, and then I'm going to mobilize it. This video is all about manual therapy for the throwing athlete as compared to some of the other videos where we're focused on exercise interventions and throwing techniques. We did a similar series with the ulnar collateral ligament with good success, so we thought we'd bring this one to you guys. So one more time, I'm going to grab underneath his hand. My body is actually turned so I'm facing more towards him and I'm oriented more towards his head. Then I put his elbow into the crease of my hip so I don't have to work really hard. Then from there, I take him to the point where I start to hit some resistance and internal rotation. Remember, I've got him up into abduction. I come off of the acromion, take him to that point. See the angle of my arm? When people do this incorrectly, they're here. They can only drive posteriorly. And then I can drive inferiorly in accordance with the orientation of my forearm. I can do a contract relax here. So push up into my shoulder and relax into my shoulder. So he's doing external rotation. I take up the slack as he relaxes. Push your shoulder out of the socket. Reach, reach, reach. Okay, pull the shoulder in the socket. Good. So I'm activating in all directions. Reach to the floor. As he's reaching to the floor, I'm going to give him an inferior glide. And that's the thing. I can hang out in that inferior glide for 5-10 seconds. I can hang out in that inferior glide for a couple seconds, or I could do it for a little bit longer depending on what the patient and the athlete tolerate. So that's one of our favorite mobilizations there. What I like to do from there is check horizontal adduction, find out when that medial border starts to wing off the rib cage. From that point, I get my arm in a line with his humerus. I drive posteriorly as I adduct him across. So I'm centering the humeral head in the socket. What often happens here is people get pinching in the front of the socket because posteriorly they're too stiff as they come into adduction. If they are limited here, I just compress posteriorly. I hold that scapula onto the rib cage with my non-mobilizing hand. I can manipulate that and use more internal rotation. Sometimes not tolerated well. I can use more external rotation. Sometimes it's tolerated a little bit better. Then I can reassess. The key is to assess and reassess. And if I say, okay, still a little bit tight here, maybe I'm going to do some contract relax. Here's my hand positioning, acromion just off. You see the orientation of my forearm. Push up into my chest, Tony, and relax. Chest and relax. I can hold this up for up to 2 minutes if I'd like. I'm not working real hard. I'm actually not mobilizing here. I'm applying about a grade 1 to 2 mobilization with my left hand here, just to center the ball in the socket. Those are my favorite 2 mobilizations for individuals with a torn labrum, specifically slap tears, because I can mobilize in the opposite direction of the tear and take some shear stress off of that labrum, especially if they have an inferior capsule restriction, which I see often in my labral tears, I can always do some form of oscillatory stretching and contract, relax. A lot of people think just because you're in a mobilizing position that you have to provide a joint mobilization, which is not actually true. I don't have to necessarily glide or even traction or compress the joint. I could just get into that position, contract, relax to the point where I've either normalized his range of motion or felt like I'm not getting any more range of motion. And then if I decide to and I feel that it's indicated based on my prior assessment, I can apply a mobilization at that point. Those are my favorite 2 manual therapy techniques for athletes with a torn labrum. You'll have to see when these apply. I'm not saying to do these with every athlete, nor am I saying that they're always indicated. But often I find in my throwing athletes, these are my best 2 mobilizations. And if one doesn't work, often the other does, especially my internal rotation stretch, because I can traction that, I can compress it, I can glide a little more posterior, a little more inferior, depending on what the athlete tolerates and what the athlete needs, or I can just do a contract, relax in that position and work on the muscular system, get them to a full range of motion without actually gliding it. You're gonna see a lot of athletes, particularly younger athletes, who don't have any sort of capsulo-ligamentous restrictions that are gonna limit their range of motion. In fact, what they have is just a muscular restriction or sometimes just guarding where I take them here and they're tight and they're not letting me go. Those are very different things. So make sure you assess properly, apply these techniques as indicated, and we'll see you guys in our next video of this series on exercise interventions, which are ultimately more important to get your athletes back on the field. We'll see you guys there.